So moving right along, I'll introduce my co-chair once again, Anneke de Haan, and about the randomised trial that they ran in Groningen in the Netherlands for Ledderhose disease of the feet.
Yes, thanks again. Well, then we switch to Ledderhose disease. We haven't heard yet, but I will take you through the results of our randomised trial we conducted in the Netherlands. Again, the disclosure is the same as in my previous talk. Then briefly about Ledderhose disease. Well, Ledderhose disease is the plantar type of the fibromatosis. It's also benign, and clinically patients present with nodules and cords under the sole of the feet. In the early stage, in general, patients do not have any complaints from this disease, but when it's progressive, the main complaints are strain of the fascia. Patients can have a lot of pain, and the pain especially might lead to disability in daily life, especially when patients are walking or running or standing, but also in rest. A lot of people report that they wake up in the night with extremely pain from the feet. So the disease can be very disabling. The treatment options, there are several non-surgical treatment options. In the early stage, patients often get insoles fitted in their shoes to release the pressure from the nodules and the cords. Then shockwave therapy by physiotherapists is mentioned, but also not evidence-based. Injections with corticosteroids is something that is mentioned as a treatment solution, and radiotherapy, and the surgical treatment options of a partial or a complete fasciectomy. But from the surgery for Ledderhose disease, we know that there is a high risk of recurrence, and it might have severe side effects. So in the Netherlands, surgeons are not willing to operate anymore. So from the literature, radiotherapy seems the preferred treatment option, but so far only retrospective trials were reported, and therefore we have a lack of high-level scientific evidence. And that was the reason why the treatment was not reimbursed anymore since 2013 in the Netherlands. So there was a need for a prospective randomized controlled trial. And with funding from an institution in the Netherlands, we were able to set up the LedRad-study. It was a multicentre trial, randomized, double-blind, phase 3. 4 centres in the Netherlands participated, and we included patients with Ledderhose disease with main inclusion criteria of a pain score of 2 or more on the numeric rating scale. They had to be 18 years or older, and they should not have been treated with surgery or radiotherapy before. Once patients signed the informed consent and were found eligible, they were randomized to either receive the sham radiotherapy, so a placebo, or radiotherapy. And we stratified by gender and age. And 18 months after the end of the treatment, patients and researchers and treating radiation oncologists were deblinded. So until that point, everyone was blinded and didn't know to which arm the patient was randomized. The radiotherapy treatment was given with the electrons, 8 or 10 MeV, based on the thickness of the nodules. The total treatment dose was 30 gray, again given in 10 fractions with a split of 10 weeks after the first 5 fractions. And the patients who were randomized to receive sham radiotherapy all underwent the same procedures, but the treatment was simulated. Our primary outcome was the pain relief at 12 months, measured with the numeric rating scale, and the secondary outcomes were pain relief at 6 and 18 months, quality of life, measured with the questionnaire, toxicities of treatment. We looked into the walking abilities by performing a 10-meter walking test and pressure measurements of the foot sole, and we also conducted an economic evaluation. I will show the results of the orange-colored outcomes. First, the patient characteristics. In this table, you can see that the stratification went well, and that there were in both groups were 23 patients who were treated on both feet. So those are the patient characteristics in our trial. And then the results with regard to pain. At baseline, patients' mean pain score in both groups were comparable. And then 6 months after treatment, we saw an improvement in the mean pain score in both groups. So it dropped in both groups to 3.4 for the sham radiotherapy group and to 3.2 for the radiotherapy group. But then moving on to the 12-month follow-up, we saw that the pain score in the sham radiotherapy group stabilized, so they did not improve any further. And the patients in our treatment in the radiotherapy group improved further. So at 12 months, we had a statistically significant difference for the mean pain score. And at 18 months, the patients from the radiotherapy group even further improved. So the mean pain score was 2.1. So again, a statistically significant difference between the two groups. With regard to quality of life, in green you see the line of the Dutch population in the with the same patient characteristics as our treatment cohort. And what we see is that the patients treated with radiotherapy increase in quality of life, reaching the level of the general Dutch population. And the patients from the sham radiotherapy group do not improve in quality of life. So also on quality of life, we see that patients from the radiotherapy group have a statistically significant better score. When we look at the toxicities, we did not find differences between the two groups. So even the patients from the sham radiotherapy group reported some toxicities. What we saw is that the main side effects reported were the erythema, the skin dryness, burning sensations, and some increased pain. 95% of those toxicities were reported as mild and only 5% as moderate. And most of the toxicities were already resolved at the unblinding time point of 18 months. The only side effect which sustained after the 18 months was the skin dryness. So in conclusion, we found a clinically relevant superiority of radiotherapy compared to sham radiotherapy for Ledderhose disease. So we recommend the use of this treatment as a standard treatment for patients with symptomatic Ledderhose disease. And as a result of the outcomes of this trial, since August last year, this treatment is available again in the Netherlands. So patients can get the treatment, having reimbursement, and so far already 12 hospitals started the treatment. Yeah, so that's really, I think, the highest goal of doing research. A lot of people worked on this trial, so I would like to thank them all. And I'm happy and curious for questions.
Congratulations, Anneke. It's a great example of translation of evidence into practice, and it must be very satisfying as the team to have been able to do that.
Yeah.
Henry?
Thanks. That was very interesting. I was waiting to hear you say what the recurrence rates were, but
Yeah, those are the results until 18 months. So the last patients in the trial have just completed the 5-year follow-up. So we hope to analyze these data in the upcoming months and to report. Yeah, I do not know from the top of my head the recurrence rate. We had some patients who were still at the same pain level, so they were offered another treatment session, and the patients who had the deblinding at 18 months and who had the sham radiotherapy were also given the possibility to start the treatment. Yeah, but so far patients are going well, but we hope to report the 5-year results soon.
So,
Yeah.
Could I just add a point then? As well as doing the Dupuytren's disease, we actually did a Ledderhose audit, and the results are outside, and it was 7% recurrence, a mean period of 9 years.
Okay. Look, we're running a little bit short of time, but if we've got a very quick comment from the front, and then maybe Heinrich, can you catch up with Anneke at lunchtime?
Thank you. It was a wonderful study. Why do you think there is so much pain still after the treatment? What's the reason they still reported mean pain of 2 in NRIs? Was it during walking, and were the nodules still there, or what's the reason for the pain?
Well, actually, I think the drop of the pain to 2 is a really great improvement. It's on a scale of 0 to 10. But 0 is no pain and 10 is the worst pain you can report. So the score of 2 is a low pain score. Yeah, so I would not say that the 2 is a high pain score. Patients are really reporting that they improved and that they do not find any disability anymore in daily life, even not with walking. We find that the nodules are softened and often not as hard as before treatment. So I would say the 2 is really an improvement,
Okay,
instead of a high pain score.
Look, just in the interest of time, we might just have to wrap it up. And Heinrich, can you just catch up with Anneke at the lunchtime break, because we are getting a little bit behind schedule now. So thanks, Anneke.
Yeah.